Thank you, Carol. It's a lovely introduction. So everyone, what I'd like to do today is, as Carol said, go over problems that you could encounter if your child has a low profile gastrostomy tube, which would include a Mickey button or an AMT Mini 1. And Jason, I'm trying to advance my slides, and there we go, got it going. So what I want to do is, first of all, talk about normal GTube care. Most of you will already know that. And then differentiate urgent from emergent GTube situations, and then talk about how to prevent them. We're going to look at a lot of pictures. You all know this. We wash the tubes with soap and water. You rotate them a complete 360 and then 1/4 turn after that every day when you're washing. You look at the site and make sure it looks the same, it's not puckered, things like that. For infants, we want to make sure that the end of the tubing doesn't get near the diaper or an ostomy if we can manage that. And sometimes I would use kind of the diaper tape tab to secure the tubing so it was away from any areas that could get soiled. We want to prevent the extension set from getting accidentally tugged on. And then we want to make sure that at night we tape the tubing in such a way that it is at the back of the sleeper. In the last few months, the FDA has come out with an alert that there were 2 toddlers that strangled from being fed at night continuously. So we want to get the word out to everyone that you really need to tape the connection out the back or have it come out a hole in the foot so that a child can't get it around their neck. Now, remember when I talked about rotating that G-tube every day? If you look at this area right here on the G-tube and you look at this spot right here, you can tell that this did not get rotated and started causing a pressure ulcer right here. So it is very important to rotate those sites. And what will start out looking like this will end up looking like this. And if you just bring this right over here, you see this hole, this stage 3 pressure ulcer was from a G-tube that was not rotated and a child that probably laid on their stomach a lot. Now I want to call your attention as well to how close this hole or opening is to the G-tube stoma, which is directly underneath here. So less than half a dime's width away is this stoma. So if this tissue tears into that stoma, there's big trouble in River City. So these things do need to be rotated. Now, what is an urgent situation? I would say that an urgent situation is something you notice frequently at night when you're bathing your child or you're kind of checking them over a little bit. And it's different and it can be dealt with in the morning or soon, but you do not need to load everybody up and go to the emergency department. So it's a change in the skin surrounding the G-tube. It's a change in the look of the stoma or the function that's worrisome to you. And some of these examples include redness and tenderness that wasn't there, but it's not associated with a fever. Increased drainage that you can't really control. If just in and of itself, uncontrolled drainage found at 9 o'clock at night is not apt to be a high priority for an emergency department. So I'd kind of leave that till the next day, unless of course it's blood. Granulation tissue that is bleeding more than usual, or bleeding after a tube is accidentally pulled out with the balloon inflated. Now there's a definite differentiation between oozing and hemorrhaging. So if it's oozing, you can put pressure on it and it slows down. If it is literally not stopping despite anything you're doing, you must go to the emergency department. Now, urgent situations require that moment you need to go. And so these are symptoms that are causing your child distress. There are definite problems. You may not be able to figure out exactly what it is, but you know there's a serious problem and your child has systemic signs. In other words, they are inconsolable. You can't use the tube or they have a fever. So redness and tenderness were on the last slide, but this one has the addition of a knot or kind of just a raised area around the stoma with fever and with or without drainage. And sometimes when it's pressed on, pus comes out. I think we all know what that's going to be. Traumatic removal of the G-tube where the balloon was inflated and now you cannot get it back in. That is a serious problem. Bleeding that is not stopping, I talked about that on the last slide, and then black drainage. Hydrochloric acid mixes chemically with the iron in blood and causes it to turn black, and that would indicate a peristomal or around the G-tube ulcer of some sort. And then skin breakdown that is significant. That second hole that I showed you on the very early on the slide where it wasn't rotated, that would have been an emergent situation. So these are some problems with G-tubes that I'd like to go through. And again, they are on a spectrum. That means that they can be everything from mild to, wow, I got to do something about this. Erythema is a Latin word for red, and so redness. So we're going to, and cellulitis is Latin for inflammation of the cell or the tissue. So let's go through some of these conditions that could be urgent or emergent. So there's redness. Is there also pain or tenderness? And tenderness is when you touch it, you can still use it, and your child, you know, flinches a little bit, but they don't cry out. Pain, I think any parent knows that. Is there drainage? And if there's drainage, a barrier cream such as Desitin or zinc oxide, calmoseptine is a product that wound and ostomy care nurses use. It's a great product. Some kind of a drainage barrier cream would be helpful because erythema can indicate, be caused by maceration where the site is wet. And if it's wet, it's going to be much more tender. So we need to keep the site dry and protected from drainage. Now, if it's just red and it's getting more and more tender, I have always suggested our families use an over-the-counter antibiotic ointment. They can buy at any pharmacy or Walmart, whatever. Use it for 3 days. And if your child is getting better, keep using it for 7 to 10 days. If not better after 3 days, and it's not terrible, they still need to seek help. They need to call their provider and get some more guidance. They may need a stronger antibiotic ointment, or they may need to be seen. Now, a GTube cellulitis. This is where the site is red and things are not looking good at all. If there's drainage, use a dressing. And there are all kinds of dressings on the market. We can provide some that are high, that kind of specially wound and ostomy care. Some people use these dressings that they get on the internet that have a little snap and they're washable, but you need to use a dressing. That site needs to stay dry. You need to wash the site more often, but sometimes we have to stop using soap because that can irritate it even more, and then just use water. We need to make sure that the tube is not moving excessively, whether there's trauma, because that can make the stoma get bigger and then cause more leakage. And I'll show you a FlexiTrack on this next slide. You're going to need to call the provider for a possible systemic antibiotic. In other words, something you put down the tube and that kind of thing to treat this problem. And then depending on the severity, this will be an urgent or emergent situation. And I'll show you some examples. So you see here, this product is called a FlexiTrack. And for this child, I would have cut it longitudinally. It will still hold the tube in place, or the extension set if the tube's getting yanked on a lot, and protect the skin. This is an old time Foley catheter. But I bring this up because here is the cellulitis. See this? Along this line, you can see the margins, or whatever you want to call it, is diffuse and not well defined. Here you see an area of swelling along an incision. This was an open laparotomy. And so this could be a little hernia. It's probably not an abscess. Right here, you see what used to be granulation tissue, but skin has grown up on over it, and now it's epithelialized and is technically a keloid. So this cellulitis is probably a developing infection from something. Now, I call your attention to this, an ostomy bag, because the proximity of this ostomy to this G-tube could well be the reason for this cellulitis. Perhaps the bag blew off or broke, that came unsealed, and some stool contaminated this site. So superficial from a really deep cellulitis. When you press on the redness and you pull up, is it white? And if it's white, that's called blanching, and that's more superficial. If it's mild redness with some or no discharge, that is an urgent. It can be, you call it in, you ask questions. Tenderness versus pain. Anytime there's significant new onset pain at a G-tube, my recommendation is that you call someone regardless of what time of night it is. Something is going on. I don't know what. No one knows what, but it needs to be worked on. And then time. How long has this been going on? Quite a while, not very long. The rate of change is as important as the change. Always remember that. So drainage. Drainage happens a lot with G-tubes, and it can change over the course of your child's experience with G-tubes. Is it formula? Does it look like formula? Is it mucus? Is it pus? Purulent fluid is pus. Most people know what pus looks like, and they know the difference between pus and formula, I will tell you. So if you think it's pus, it probably is. I'm just going to tell you that. And if you press on it, and you get fluid out in a certain spot, that is probably, again, purulent drainage. Is it associated with anything else? Children that have an upper respiratory infection have more secretion, so they have more fluid going down into their gut, but also that inflammation in their upper respiratory tract will affect their gastric emptying, and so their stomach doesn't empty as well. Teething, same thing, swallowing more secretions may cause more kind of a mucousy drainage. Change in bolus feeding volume. If your child is bolus fed and someone tells you to go from, say, 3 ounces to 4.5 ounces, perhaps you cannot go from 3 to 4.5 at one time. Perhaps your child is going to do better by going to 3.5 ounces for a couple 3 feeds, and then 4 ounces for a few feeds, and then go to 4.5. So we want you to get to the 4.5 feeds that the dietitian or the physician told you to do, but we may have to just take a step or two or a couple minutes to get there. Now, again, is this new or chronic? If it's chronic, it may be a different deal, but if it's new, check the water in the balloon, and you should be doing that about once a week anyway. And then again, is this affecting your child acutely? Did this just come up? And if it did, it's more likely something that needs to be dealt with. So, exposure of the gastric mucosa or greater omentum is caused by too much movement of that gastrostomy tube or pulling on it. And this is an urgent gastrostomy tube issue. That child needs to be seen in a timely manner very, very soon. Doesn't require an emergency department visit necessarily, but they need to be seen. Now, you can use a G-tube attachment device to try to secure the G-tube, or what you can do is remove that gastrostomy tube for 30 minutes and then work your way up to 1 to 2 hours to shrink that stoma back. Now, let me show you what I mean by that. This is a fuzzy picture. But what you can see, this is actually the stomach, and it has torn away right here. And again, this is an old-fashioned Foley catheter, but this problem is not an old-fashioned problem. I would see it on a regular basis up to the very day I retired from working full-time. The skin has torn away from this. And so what we would do is actually take this G-tube out, if it was a Mickey button, every day and leave it out. And we might leave it out for up to an hour or 2 hours to get that hole to shrink back, because it really needs to do that. Now, this is a better picture. And what this shows, if you look at this edge of the G-tube, look at how it has literally rubbed raw, this area. Now, this child has a 12 French 0.8 centimeter G-tube. I call your attention to this because I bet that this should have been upsized and it literally just was too tight and the friction caused this situation to occur. So again, we would take this tube out and leave it out and let that stomach and that omentum shrink back down and do that. It might take 7 to 10 days, but this is the treatment for this. You never want to do this without a physician order, though, I will tell you that. This is a flexi-track, and this is where we would hold it straight up so that we wouldn't have to worry about it tugging and pulling. So we have used flexi-tracks on occasion and had pretty good luck with that. Now, granulation tissue. A lot of children will have granulation tissue. Now, the term itself, granulation, is a physiologic or a normal response to wound healing. And we actually want there to be some granulation in the stoma or the tract between the skin and the stomach, because that causes scarring and it causes the tract to actually mature. So part of turning that G-tube, other than the fact that you don't want that balloon to stick to the gastric stomach lining, the part of it as well is to irritate the tract enough to cause scar tissue to continue to form so you get a mature tract. Hypergranulation tissue, which is what you see when it bubbles up on the skin, is a non-physiologic, pathologic response to continued irritation of the tract. It's caused by it getting pulled on excessively. That's why with flexi-track is really helpful. Or somehow securing that extension tube in the diaper tab, something like that, so it doesn't get pulled on. The younger the child, the more likely things are to get pulled on. Again, we don't want that extension set left in when a child is getting bolus feeds. It can also be caused by drainage or fluid just sitting on the skin. So we want that site to always stay dry. We do not believe or recommend a dressing on every G-tube. That is not a good idea. It needs to be open to the air as much as possible. But when there's drainage, we've got to have a dressing. Now, silver nitrate can be used, or we use a product called granulation, which is a pickling salt, potassium alum, that is put in a methylated ointment or a cream to kind of soothe it. Now, you have to put a barrier cream like Aquaphor, Vaseline, Desitin on the skin around the stoma prior to using granulation. Use it multiple times a day. This product is available on Amazon, but must be used with physician, your provider knowledge and sanctioning of it. A steroid cream can be used. I caution against using that routinely. It will thin out the skin layer around the G-tube. So you want to be very judicious if you use steroid creams. If not treated, granulation tissue is going to get infected. It's going to increase in size. It's going to bleed. It's going to be a mess. If a G-tube needs to be changed out and there's granulation tissue, I recommend that you treat the granulation tissue before changing the G-tube if possible, because it is very painful to put a new G-tube through granulation tissue. Take my word on that. And the key thing here is prevention. Now, let's look at granulation tissue. You can see granulation tissue right here. It's that kind of beady stuff, and it doesn't have to be completely circumferential as this is. And in other words, it doesn't need to go all the way around the G-tube tract, the stoma, to be granulation tissue. Now, a couple things. This granulation tissue has had silver nitrate applied recently. You can see how the dark areas that will slough off with a little washcloth over time. But you can see here, whoever used it did it incorrectly because they burned the skin right here. The reason for that is all these children are going to move. It's not supposed to hurt. I've never used silver nitrate when it didn't hurt the child. So we would protect the skin with Vaseline or calmoseptine or zinc oxide, anything. Protect the skin and then do it very sparingly. This next slide here shows what happens when people are too aggressive with silver nitrate. I gave this talk to our department one time, GI department, and one of the attendings came up and said that she knows that she's the one that did this when she was a fellow, and she didn't realize she wasn't supposed to use that much silver nitrate. 1 or 2 sticks of silver nitrate is quite sufficient. That she used 3 or 4, and you can see here the skin is going to slough, and that's the idea. But look at this. Look how painful this is. So there's a chemical reaction here that affected the skin, a chemical dermatitis, quite tender, quite painful. Unfortunately, not really treatable, has to go away with time. Very sad. Yeast. A fungal infection is not uncommon at a GTube site. For one thing, if a child has it in the diaper area, it can crawl up the skin and affect the GTube. But it absolutely must be treated, because I have seen Mickey buttons and AMT buttons and peg tubes actually break off because the fungus, the fungal strain embeds into the actual tube, and it breaks it apart. Now, couple things about a yeast infection. First of all, it will go down into the tract. This is a very key point for you to think about. I was talking to a friend of mine who's a dermatologist one time, telling her about this, and she suggested that I use half-strength vinegar 3 times a day and let it air dry, and then apply the antifungal treatment and try to get the half-strength vinegar to go down into the tract. Now, you want to keep this open to the air as much as possible and as dry as possible to prevent a yeast infection. If the area is dry, if it's a dry yeast, you want to use an antifungal cream. But if it's moist, you want to use an antifungal powder and try to get some of that down in the tract. It is an urgent situation. It must be treated. Now, here is my recommendation. You need to change out the GTube about 7 days into treating for a severe cellulitis or fungal infection. Otherwise, the new GTube will reseed the area. So change it out toward the end of the treatment time to a new tube, and that will help you with not having this problem come back. Here is a yeast infection on the skin, and as you can see, it goes clear down here, and if you look closely, it's down in the diaper area as well. But up here, you see that it's moist, and so we would use a powder on this for this child. Down here in the diaper area and where it is dry, perhaps a cream would be better. Okay, dark bloody drainage. I talked about how hydrochloric acid mixes with the iron in blood, and it becomes a black gooey mess. So what we want to do with this is use acid suppressing medications, make sure the GTube rotates easily in the tract, and change it out. Here it is right here. You can see this, and that GTube is too tight. I think I'm getting behind on my time a bit, so I'm going to try to pick up my pace. I'm sorry. I think I'm over. Severe cellulitis could be related to adhesives. We want to look at wound care for that and systemic antibiotics, and this is a severe cellulitis. Any parent who sees this knows they need to go to the emergency room. Okay, the GTube is doesn't rotate easily, needs a longer shaft. This is a tip. When a child changes from a Mickey button to an AMT mini one, they often need to go up a size because of the way those two balloons seal differently. The mini one often needs to be a larger size or longer size. And you can see here, this one is too tight. It's puckered down in. It's absolutely essential to prevent gastric lining ulcers to actually resize these G-tubes as your child grows. So in summary, gastrostomy tube placement is pretty common for children who need long-term enteral nutrition. Complications may be common, but they don't have to become urgent or emergent. Growing up with a G-tube means it has to be resized periodically. And again, what Dr. Mercer said, I couldn't agree more with. We absolutely must feed these children orally. So now I would like to go to our next speaker, who I want to introduce